It is a therapeutic vaccination in chronic viral hepatitis. And the thing is this, it is a little complicated because the concept, identity, definition, fallacies, mechanism, and several qualities remain regarding the therapeutic vaccine. Why we call it as a vaccine? Number one, the antigen has been used here. So it is completely different from the prophylactic vaccine because the prophylactic vaccine gives the protection and therapeutic vaccine is for the treatment. This point I'm discussing for the last 20 years, still the people are in confusion. What is the nature of the therapeutic vaccine? And it's a second thing, we must remember that it's an immune therapy and different from antiviral intervention. So again, the concept, outcome, scope, and limitation is different. And I'm not here to discuss all these points. So I'll be saying that the role of cccDNA, integrated DNA, quantitative surface antigen, and other markers need re-evaluation when we discuss about the therapeutic vaccine. To major causes in chronic viral hepatitis, my topic is therapeutic vaccine in chronic viral hepatitis. So in fact, therapeutic vaccine can be used for all etiologies, but two major things which has been going to be studied about the therapeutic vaccine. One is the hepatitis C virus and the hepatitis B virus. And I'm introducing 7 clinical trials on vaccine development against hepatitis C virus. First I come hepatitis C because I'd like to take a little more time for hepatitis B. Well, this may not be seen very correctly, but in case of the hepatitis C virus, we have not been able to develop a prophylactic vaccine even. So there is studies going on, and these 7 are the clinical trials, a phase 1 and 2 level for the development of the hepatitis C vaccine, prophylactic vaccine, but not for therapeutic, but also people are checking whether this can be therapeutic vaccine as well. Now, let us come to the ethical basis of development of therapeutic vaccine for treatment of chronic hepatitis B. So why? The major limitations for the ongoing drug, the commercial available drug, we know people are using for a long time. So it is a non-cytopathic virus. So the virus has no role in directly causing the damage of hepatocytes, there is the inflammation, or fibrosis, or hepatocellular carcinoma. But if the virus can be reduced, we hope that something will happen. So there are some problem about the safety and efficacy issues, and also the most of the treatment is not finite, it is infinite, which is not bearable in the developing countries. Second thing, in the right side you can see that here there are many drugs are developing for the antiviral therapy. For example, entry inhibitor, cccDNA, RNA interferers, core protein. And if we all develop all these drugs and give to a patient, the patient is not to be cured better than today, and this is not a finite therapy. And the last one is very important. We all know that there is a topic that elimination of hepatitis by 2030. And you can see here, not very clear, that almost 80% people are not known about their hepatitis B virus infection in chronic stage. And very few people, less than 10% people is under treatment. So if any infinite treatment, for example, in India, there is the 140 crore or 150 crore people. And if we try to find out all these people, we cannot give a treatment for infinite time for this patient. So we need a finite thing. With this, actually, people started to treat by using therapeutic vaccine from 1980s to 2010. First of all, Diagnostic started it. Then some, I've given here some study. Those have been reported. Also, we have studied something. But ultimately, it was found it is safe but transiently effective, no sustained effort, no long-term follow-up, no mechanism of medicine, and no phase 3 trial. So ultimately, surface antigen-based vaccine, that is preventive therapy-based vaccine, is not therapeutic. Now, I've just wrote it here. I'm introducing 10 clinical trials for vaccine development against CHB, except our trial, which I'll be giving the last one. So this 3 is usually, so these all have been registered into the clinical trial. So I'm just showing those things. All these are going in the phase 1 or phase 2. No phase 3 trial. You can check all these things. So all is recorded in the NCT. They are mostly assessing the safety and efficacy, and some trials are with the antiviral drug as well. So these are the ongoing trial. is going on. So let the trial finish and the safety data comes on. Then we can go for the phase 3 trial, and then a long time will be required for the marketization. Well, now I am not told about our study. So we are trying to develop a therapeutic vaccine from 1988 and to 2004. So it is a work of 36 years. And first, we started with the surface antigen vaccine from 1988 to 2008, 20 years. And then the next 16 years, we are developing a new vaccine and working on that. So to have the clinical concept and to have the basic science, we developed HBV transgenic mice, which give H-based antigen, DAN particles, but they do not have the hepatitis. We validated the concepts and clarified the mechanism, how the therapeutic vaccine should be built. And then also at the same time, we are progressing how the therapeutic vaccine was getting and what are the problems. And after 2 decades, we found that the prophylactic vaccine is not be a therapeutic vaccine. So we developed a vaccine. In spite of surface antigen, we use surface and core antigen. In spite of 10 to 52 microgram, we use 200 to 400 microgram. In spite of 3 to 12 times, we use 15 times. And the most important, we use not only parental, but nasal and parental vaccine. So this was developed, which our work, and developed in Cuba. And we just started to give the trial in the, all the trial before was done in the NAC-treated patients, and we started the trial in the treatment-naive patients. And then we came to the NAC-treated patient. And also, one of our target was to the elimination of hepatitis and progress for a FENET therapy. And we did it by nasal route to have the given for the third world population. And this is the vaccine, a combination of surface antigen and core antigen. So I'm not going to describe it, I don't have the time. One important thing is that the core antigen is very, very much important, because when you give core antigen through nasal, and we found that there was the antibody production and CTL production in vaginal wash and lung washes. So this gives a beautiful systemic intervention. And also we found the productions of the CTL in the liver, but they did not damage the liver. So we just proceed this with the clinical trial. And so all this work was done in Japan for 20 years. Then, but the Japanese authority did not give the permission to go for the clinical trial. And then a brave hepatologist of Bangladesh came forward, Professor Mamun al-Mahtab, and another brave hepatologist encouraged me, and he gave me the leave for a long time, Dr. Shunji Mishiro. And the next 6 slides is about the clinical trial and outcome. So this is the phase 1-2 clinical trial with the vaccine in 20 patients, and we found very excellent result. First of all, the first thing was the safe, and the efficacy was nearly 50%. And we also elucidated the mechanism, including the activation of the dendritic cell. So this is the result of the phase 3 trial we supported. And then the one important thing we did, this is after the 48 weeks after treatment data, then 2 years, 3 years, and 5 years data. Possibly this is the first immune therapy for CHB and for any type of thing that the same patients was evaluated for 5 years. And now we have completed the 10 years follow-up, and that will be coming very soon of the same patient. So 160 patients was taken, and 80 patients received therapeutic vaccine, and 80 patients received pegylated interferon. So this is a neck-to-neck comparison. Well, then we started vaccine trial in Japan. After they find it was not possible in 2008, we did it in 2015. And now a big study is going on in 7 universities of Japan. And their data also show that the therapeutic vaccine, they did the whole thing in the nucleoside analog experienced patients, but they find that the surface antigen is also coming down, and also they have a very good role in production the anti-HBs. So if I compile this thing, we find one thing in generally. So all these things is published, you can find it. It is safer than pegylated interferon, the phase 3 trial, which was done in 160 patients. Sustained antiviral capacity bigger than PEG interferon, and about 60 to 70% patients remain HBV DNA negative at the end of 5 years, and also similar result we are finding at the end of 10 years. And liver damage production that we found from the ALT and the fibroscan data, it is also better than PEG interferon. And hepatitis, so I have not yet published it, and going to publish it. out of the 80 patients who got NASVAC, none developed liver cirrhosis, whereas 10 patients receiving pegylated interferon had the liver cirrhosis, although at the initial stage, they all have the similar level, almost no marked fibrosis. So we started a new challenge with NASVAC. So our target was the elimination of hepatitis and what I should say, a treatment which will be a finite duration. So we got NAC-free status in CHB patient, and we started it before 2 years. So what we did, it is a preliminary study, 30 patients with the CHB and receiving nucleoside analogs for several years, 1 to 10 years was used in this study, and 15 of them, NAC was stopped. And in 15, the NAC was continued with the NASVAC, that is our therapeutic vaccine. So 15. And NASVAC was given for 5 nasal, followed by 5 nasal plus subcutaneous. So it took 4.5 months. So it is a finite. And after that, we started follow-up. So we checked ALT. There was no hepatic failure. There was a rise up to 400, but it came down without any therapy. And similar thing happened about AST. Fibrosis was no change in the group A. That means after the NAC and compared to the NAC plus NASVAC. And Q surface antigen, although downward slightly, but significantly. So this is the thing. So now we have taken the blood, the estimation has been done, and after 2 years, they have no hepatic flare and no increase of fibrosis or the other problem. So we are going to tell, but we like to see more, that the nucleoside analog can be stopped if replaced by NASVAC. So you don't need to continue with the nucleoside analog, but so it is only the 15 patient. So we are now studying a big trial with 100 patients. So we'll be seeing this thing. The proposition. So therapeutic vaccine seems to be control HBV replication. We have the documented data and the containment of liver damage. So there is the ALT control in about 70 to 80% cases. And they also regulate hepatic fibrosis. Some patients showed a little fibrosis in Kremen, but like PEG interferon, none of them developed liver cirrhosis. And this continuation of the antiviral seems to be possible in CHB patients by replacing with the therapeutic vaccine, that is the NASVAC. But this is a very small study we did in 30 patients, and the future study will give something more. And now come about the attainment of the target of elimination of hepatitis. So we need a finite treatment, and elimination is not to be going to take place in 2030. The WHO goal will not be attained, but sometimes in the future this can be attained. So this is more beautifully visible that the treatment is getting only 5 million HBV, and we like to bring it to 80%, which may be several millions. So we are proposing a finite therapy, that is this immune therapy, and maybe the more clinical trials are at present. We are contracting many clinical trials over here, and also phase 4 clinical trial is continuing in 300 patients in Cuba and Angola and other countries. Unfortunately, due to the involvement of Cuba, we don't get the permission from the FDA, so we'll be trying to develop it in the South-South collaboration. And finally, I like to come. There is no conflict of interest about this thing. This entire therapy has been conducted with a researcher-based support, not from support from any company or other things. And I must acknowledge Professor Mamun's contribution. He was supposed to come. He could not come. I am coming directly from Dhaka. You know, there are some problems and something in Bangladesh, so he could not come. But I must tell this thing. And I also acknowledging INAZL and Kalinga Gastroenterology Foundation, Clinics of Hepatobiliary Disease, and Indian Society of Gastroenterology, and other several institutions, for example, Chandigarh, Lucknow, Kolkata, for providing the chances to provide our data. And now, after doing things at the same time, I've just established a small laboratory in Bangladesh, and we are now developing a cell-based vaccine for cancer. And this will try to pick up the cancer antigen in situ by providing them through RFA or by other devices. And then they will produce the immunity. So this cell-based vaccine can be in a better position to treat the cancer. So thanks the organizer for inviting me. And thanks for providing the opportunity to discuss these issues. And with all the best, I just like to finish here. Thank you.
So we can have questions from the audience, but before the audience asks, a couple of queries from my side.
Yes.
What is the basis of using core antigen in addition to surface antigen, number one? Number two, have you determined any functional cure in these patients? That means surface antigen being negative. And number three, which group of patients did you take for the therapeutic effect? Was it immunotolerant, chronic hepatitis, E positive, E negative? That information wasn't very clear in your data.
Okay. So let me come first from the last one. So which patients was chosen here? So the trial was conducted in Bangladesh. It was in treatment-naive CHB patients, both E antigen and E antibody positive, but all of them had elevated ALT, usually 2 times more than normal, and with fibrosis not considerable, and definitely no hepatocellular carcinoma. So these are mostly the inclusion criteria. So HBV DNA positive, more than 10 to the power 3 for the E antibody plus, and more than 10 to the power 4 for the E antigen plus. And all of them definitely surface antigen positive, ALT 1 to 2 times during the last 3 months, and with the minimal fibrosis. This is the inclusion criteria. Exclusion criteria, as usual, so there is no other high level. Your second query is most important. Why I use the core antigen and not the surface antigen? So we tried surface antigen for 20 years. Ultimately, we found the limitation. Surface antigen induces the protective antibody when the person will be infected. And these are not able to control the virus. Core antigen specific CTL and surface antigen specific CTL has been taken to do the adaptive experiment. And surface antigen specific CTL or antibody is not to control the virus. Everything is done by the core. What surface antigen do? They only give the NTSBs give the patrol over the circulatory system. So when the surface antigen or hepatitis B virus enter, they kill it either by complement mediated or macrophage mediated. So core antigen is the firm thing which can give you the CTL, but the core antigen can give a big CTL flash which can destroy the liver as well. So we first check the in the transgenic mouse whether it do that thing or not. So this is the most, and even I have the paper, so 2012 published in Antiviral Therapy and Antiviral Research, that we can only use core antigen, not surface antigen, for the therapeutic vaccine. But that trial has not been given. Your third question was? Functional cure. Well, about the functional cure, we all know the definition, that the thing is about the virus control. So I told in my first slide that the immune therapy is something which don't care about surface antigen, which don't care about the cccDNA, which don't care about the integrated DNA. Because you know that 2 billion people of the world is infected with hepatitis B virus. Out of them, about 300 or 250 million is the chronic. Out of them, about 180 million have the elevated ALT. And none of the virus, everybody has the virus. But the virus is not causing anything. So what is causing all these things? That is the immunity. This has been tried, and I have about, and other people have, in the world there are the thousands of publications. I personally checked all these things one by one. So it is the immune system. And then we found, so today I did not discuss it, then we found what is the protective immunity and what is the pathogenic immunity. So pathogenic immunity is causing the disease, protective immunity is curing the disease. And then I checked the immunity between two parts, and we found that polyclonal immunity is the pathogenic immunity, and antigen-specific immunity is the protective immunity. So to induce
how many patients lost surface antigen?
In our cases, we found only 2 or 3 patients, but most of the patient has reduced surface antigen, but not lost completely. Even without losing, or even having the surface antigen, high surface antigen, the patient maintain the ALT normal, no fibrosis. So this is the area which differ from the nucleoside analog therapy.
So what is the end point of therapy?
So end point of therapy, we think that we like to prevent the progression of the liver disease at this point. Oh, another thing, I just missed it. In Japan, the treatment has been given and they are checking the quantitative surface, Q surface antigen, and they are finding that the surface antigen reducing, but their patient was all nucleoside analog experienced patient. A recent study 1 year before, we started another therapy in the asymptomatic HBV carrier whose ALT level was normal. And this study is going on in 7 universities of Japan, and the data will be pulled. In addition to this, in 13 countries, including Singapore, Australia, Korea, the trial was done to assess the safety, and it was found to be completely safe. So we were working with a safe, maybe 50, 70, 80% effective therapeutic vaccine, and with a finished therapy. And in all cases, it was given for 10 times or 15 times within a span of 3 months to 4.5 months.
Okay, Dr. Prasad here. Well, I congratulate you for 3 decades of work in this area of vaccination. I know it's very difficult, sometimes very frustrating. So my doubts are whether this vaccine will be able to eliminate the virus completely, because I do not think that alone it can do the job. Maybe in combo it can probably have some additive value to an ongoing treatment with nucleoside analogs or tide analogs. As you said, only a very few people have lost the surface antigen, because there are some of the newer drugs which are able to even, so for example, one example is bepirovirsen. I was discussing at lunchtime with you, which looks like about 60 to 80%. Even the QHPSAG is lost. So probably commensurate with the loss of cccDNA. Whereas in your case, I don't think that sort of a response is possible here. And also you said you're stimulating the immune response. And I mean, whatever basic that I learned, that it's a cytotoxic T lymphocyte attack or NKT cells going and hitting against the virus-loaded hepatocytes by breaking them is probably to kill the virus, to eliminate the virus from the system. I do not think this can do that, okay. And probably in that case it can produce a flare.
So we should be very careful to use 2 terms. One is the eradication and another is the elimination. So as of today's knowledge, I can tell that eradication of hepatitis B virus is the impossible goal. Maybe it can be possible sometime, because the eradication means you are just checking the blood, in the blood. And when you check the liver, kidney, macrophages, immunocytes, so I have checked about 10 immunocytes in a row. When there is no surface antigen or in the blood, we found the HBV DNA by in situ. So eradication of HBV, I think impossible, but elimination, that means to bring the inactive carrier stage, it's possible. So this trial, you will understand that the phase 3 trial is done in 160 patients with only one regimen. So we need to do in worldwide manner in more and more patients.
And how many doses were given, sir?
We are giving 5 nasal first, then every 2 weeks after. So this takes about 2 months. Then 5 nasal plus 5 subcutaneous at the same day. This is also 2 months. So, and in between there is a gap of 1 month. So 4.5 months, the total regimen. So,
and why didn't you choose a DNA vaccine? Why did you go?
No, actually DNA vaccine, David's and others, and we also worked together. And I developed DNA vaccine. But I think that to get the permission to eat this vaccination, therapeutic vaccine, from the IRB and from the National Institute, it was a tough job. For the DNA vaccine...
Even a genetically re-engineered?
Even the genetically re-engineered thing, for the DNA vaccine, you can do on a small level. So it is not, so actually we have not done it. Somebody did it, many groups did it. But the thing is this, when you start something, so I'm working on this issue for 36 years. So phase 1, phase 2, phase 3, 10 years follow-up. So this is thing I can say now something. But if somebody did the DNA vaccine, other vaccine, and after one study, thing stopped. So if somebody can do, we may get something. But about the surface antigen, I am not thinking about the eradication at this point. But we may get, so you see, we are giving only 1 cool. If we can give 2 cool, if we can give with other drugs, maybe we can get some other result. But we're not certain at this moment.
Sir, nice talk, sir. Sir, just one question that with this, WHO 2024 expanding the indications to antivirals. Now, sir, what do you think will be the implication of now, because the HbSAg loss, though it is not the target, on the long term, what do you think will be the fluctuation of the HBV DNA? Because the HBV DNA itself, even without the occurrence of elevated ALT, has been known to be a predictor for HCC as per the REVEAL study. So what do you think will be the long term?
No, for the time being, we just started with therapeutic vaccine, have the phase 1, phase 2, phase 3, 10 years follow-up, and we have found that about 70% patient remains inactive carrier. So for the timing this, so we are also planning the other studies in Japan, in Bangladesh, in other countries such as the Turkey, and if possible we can do also similar things in India. So only one thing we have confirmed, that even after 10 years, it is safe. There is no side effect. So definitely we need more and more studies to do.
So the DNA also persistently continues to be low, sir?
No, DNA lost, for example, the serum DNA came below the estimation level in about 50% patients. So please go through our published paper, and you can find, because it's only 15 minutes, I just cannot tell the protocol, the way, the other thing, the DNA, so you will find the whole picture over there.
Thank you very much.